All right, welcome everyone. And thank you for joining us for Updates in Pediatrics live stream. Updates in Pediatrics is a monthly live stream program which takes place on the third Wednesday of the month at noon. Participants will receive a link following the program today for an evaluation, and you can also use the QR code that will be displayed following the live stream today. This program will be available online within 2 weeks at nortoncme.com. So I'd like to welcome our speaker today, Dr. David Lohr. Dr. Lohr is an associate professor in the Division of Child and Adolescent Psychiatry and Pediatric Psychology at the University of Louisville and Norton Healthcare. Dr. Lohr is a native of Kentucky and graduated from Transylvania University before going to medical school at Johns Hopkins University. He completed his residency in adult psychiatry at WashU in St. Louis and a child psychiatry fellowship at the Western Psychiatric Institute and Clinic at the University of Pittsburgh. Since January of 2018, he has served as the Chief Medical Officer and Medical Director of the Department for Community-Based Services in the Kentucky Cabinet for Health and Family Services. Dr. Lohr has published and presented on trends and quality concerns about the use of psychotropic medications in children, which lends to the topic today, deprescribing psychotropic medications in youth. So welcome, Dr. Lohr, and I'll turn it over to you.
Thank you, Mark. It's good to be here, and I am going to share my screen and start my slides. So we're talking about medications in youth and how to deprescribe. So we know that there are children who are treated with medications who received a great deal of help, but also there are children that we see and you see in your practice who you may find are treated with a lot of medications. We call this polypharmacy. And the truth is there's little evidence or guidance to guide you as a clinician. And so there's a need for a rational approach to look at these medications. So that's in the bottom line what this talk will do. So you will understand the concept of deprescribing, what that means, and see it as a rational, developmental, appropriate look at medications. And we'll discuss a case and some other cases, if you can, on regiments where you may think about deprescribing medications or lowering or looking at these. So we'll start with some background information, go through some principles of deprescribing, and we'll touch on the University of UoL CAHRDS Deprescribing Pilot that we have going right now. So I want to try to see if this will work. So if you can humor me by texting and giving me your answers for this. So the question is, do you routinely prescribe stimulants or alpha agonists for ADHD? So go to your phones, type in this my name and 074 to the number 22333, and then choose A or B. So I was thinking that's the case. Most pediatricians are pretty comfortable with this. So next question, how about antidepressants? Same question. Routinely prescribe these pretty easily. Again, I think that's in the standard of care. Next question, antipsychotic medications. This is something that you routinely prescribe. Also, mixture. And I think that's what we see and when we think about medications that you may be using. So deprescribing may mean different things to you based on what medications you prescribe. Whenever we treat children, we have to understand that as a clinician, we see them in our office and we prescribe treatments, but these treatments, they may have different impact based on many different factors that are present in children's and families' lives that they bring to the office. So outside of the office, there are a lot of things to consider. That includes health behaviors, social and economic factors, education and income, for example, and just the physical environment. So the actual clinical care that we give may only impact a minority of the outcomes that we want to pursue. And taking a broader approach is very important to understanding how we can impact outcomes. That includes paying attention not only to the mental health services or the clinical care in the office, but what's going on with the school, whether there's parental substance abuse, what other factors are involved. And so I've migrated to a systems of care approach as the best effective treatment for so many children that we have. And I think that as pediatricians, you guys are the medical home for these children and know, in many cases, the different avenues of the systems of care to connect. So keep this in mind with medications. So we know that children are treated with medications to treat behavioral and emotional problems. And I prescribe them, and I do feel that they work. So medications can treat depression, ADHD, other things that are very common. They also treat things like insomnia. Any medication that you prescribe or a patient takes that has an action on the CNS system, the brain, I consider that to be a psychotropic medication. But luckily, children and youth get better and their needs for medication may change. So that's one thing that this talk will get into. It's time for everybody to think about when medications may need to be changed. This slide is a few years old, but it shows that there's dramatic increases over the last 15 to 20 years in the number of medications children receive. This is a national private insurance database, and it shows that ADHD treatments have increased greatly from 1995 to 2010. But if you look at the antipsychotics, they may have the greatest overall percentage increase, that these medications are used so much more. Every medication is increasing except for antidepressants. So we see that a lot of medications being used for kids. A little more background in the world I'm in now. As a director of foster care, we track medications in children who are in the foster care system. And our data shows that about 40% of all kids in foster care will receive at least one psychotropic medication over the last 12 months. And looking to the right, you can see that the most common medications are antidepressants, the alpha agonists, stimulants, and the antipsychotics. What we also see is that there's a number of children in foster care that have polypharmacy. This is data that Dr. Davis published with our group that looks at high-level polypharmacy, 4 or more classes of medications. And it shows that over the years that children in foster care, up to 30 or more % of all children in foster care will receive high-level polypharmacy over the course of a year. And this is a group that I try to track and oversee to help reduce that need. So what is deprescribing? So deprescribing means different things, and it can, in some cases, it can be worries that it will be a negative connotation, but it really just means taking a rational, structured approach to looking at each and every medication a child takes as to the indications, how they're being used, what the risks and benefits are, with the goal of getting to the right number of medications, the minimum effective dose. And also a big part of this is considering what is right with the values of the patient and family and to their goals, preferences, and functioning. And as part of this, we've then developed the pilot from the CAHRDS program where we're talking about the deprescribing, or we're looking at Medicaid data on psychotropic medication utilization in Kentucky. And as part of this pilot, we're providing training like this that raises awareness for deprescribing. And I also will be talking about the toolkits and materials that we have in order to help guide this discussion and provide tools for you going on. So it's very effective to think about what medications can do. They are effective and appropriate. Medications are useful to level what I call the biologic playing field. That means they either control symptoms such as inattention or insomnia, they target neurotransmitters perhaps, they treat established mental health disorders like depression or ADHD. And in children with mental health disorders, they allow youth to actually benefit from psychosocial therapies in the least restrictive setting, keeps them out of the hospital. But what medications cannot do is to go back and change what's happened to a child and how those experiences are part of the child's identity. They don't provide coping skills or a sense of safety. They don't improve those social determinants of health. So it's important to realize what medications can do and they can't do. I also feel like it's important for everyone to understand what are the ethical considerations when we prescribe multitude of medications, polypharmacy to youth. We have to realize that there is very little evidence base for this. You have FDA indications for medications that are used as guides. And in a couple of cases, you have medications in mental health that have been proved as adjuncts or add-ons. One example is guanfacine, extended release for the treatment of ADHD, or clonidine. But when it gets to children who are on 3 or 4 medications, we really don't know the evidence about how it's effective. We also don't know really the side effects. We think that the more medications a child is on, the more likelihood they are to have things like metabolic syndrome or tardive dyskinesia. It's also important to realize that when you have children who are developing, their brains are growing and they act differently to medications. It's been said that in children who are developing, the brain can assimilate medications versus accommodate. That means that, say, if you're treating a child with an antipsychotic for a certain behavior, it could actually change the set point for that behavior so that in the future, medications may not be as effective. We don't know that for sure, so we're really looking at animal studies. The bottom line is we just don't know what the long-term outcomes are of these medications. And as children are under the age of consent by status, there's questions of justice. Who are making the decisions for these children? Are they parents who have a biological link? Is it a foster care parent or a worker, a guardian who also makes the decision? So I think the questions of justice and autonomy are important. So I want to stop and illustrate a little bit case example to bring this to life. This is a case that I actually reviewed a couple of months ago on a 4-year-old female who was referred for me to medical director because she was having tantrums, a lot of sexualized behaviors. She was hyperactive, impulsive. She wasn't sleeping, and she's pretty aggressive. And we weren't sure what to do. She also had a history of fetal alcohol syndrome. She was born exposed to Suboxone, and there was a history of physical abuse in her background. Her family history was notable for drug abuse and exposure to all the things that go along with the drug exposure life. This is a child where TPR was scheduled to happen. And so in the meantime, she is living in a foster home with her 7-year-old sister for the last 8 months, but she's still having a lot of trouble with aggression and impulsivity. She has a speech, and she has IEP through school that calls for speech therapy, but she still hadn't been toilet trained. And at the time we reviewed her, she had a therapist, but had not seen a psychiatrist in 3 months. Sometimes children who are in these foster homes may go several months without seeing a psychiatrist. So these are the medications that were present in the review. She was receiving Adderall XR, 10 milligrams in the morning for ADHD, fluoxetine 20 milligrams in the morning, guanfacine 2 milligrams 3 times a day, mirtazapine or Remeron 15 milligrams at night, trazodone 100 milligrams at night as well for sleep. So these are the medications. And so in our discussion, we talked about deprescribing. And so when we think about deprescribing and you have a child in front of you, you want to think, is this a right time to deprescribe? The short answer really is yes, because again, deprescribing is just a discussion or a consideration of all the factors. So really we want to consider deprescribing if we have concerning medication practices, if there's a child there's less stress in the use life, if the child has been going to therapy and seems to be doing better, or in some cases, if the medications have not been helping and they actually are worse. And then if there's a change in the use health, we would want clinicians to think about the deprescribing process. So for Hannah, there are concerning medication practices that exist. I will talk about these later, but she's a young child on multiple medications. She's a child that is in a foster home that is just starting to get consistent therapy. Perhaps some of her traumatic and exposure may be diminished. Maybe she'll develop a sense of safety. The team is in process of sending her out for neurodevelopmental evaluation, so we will have more answers about her makeup, her intelligence, and other factors. And then the team is referring the family for family services, including respite and some in-home services. And we're going to be getting labs. So for Hannah, it's a good time to bring this up with the providers that maybe we need to be looking at each of these medications to see. So getting into deprescribing, when you're ready to look at this, you're going to be looking at the child. You're going to be looking at the risk-benefit analysis for each medication a child takes. Again, the indications, the role within their overall care, the short and long-term side effects. We want to pay attention to the natural course of illness. For example, depression and anxiety don't last forever. Trauma exposures and trauma-related sequelae can improve if the child's in a safe place. And it's a periodic process every so often. I've attached a picture here of the medication history tool that's in our website that's available for you to use that allows you to go through and look at these questions on each medication. So once you've done this, you, the provider, the family, the youth, will sit down and talk about each medication that a child is taking. We want to know who prescribed it, what is it for, why are they taking it, and how long might they need to take it. Medications don't always need to be taken forever. Again, what are the benefits and the risk of this? How can it help and how is it causing side effects? What are the youth and family preferences? They may feel very strongly that they need to stay on a medication, that they're not ready. We talked a little bit about concerning medication practices. These are pulled from the Illinois Department of Children and Family Services. And it's of note, in Illinois, if you are working with a child in foster care, you have to go through a 1-800 number in order to get consent, central consent for all medications you're prescribing a youth. And so if you have 4 or more medications prescribed to a child, I describe that as high-level polypharmacy. If you have 3 or more medications to a child less than 6, I feel like there's a concern. The risk and the benefits don't always match up to the evidence. If you have a child that's really young, any medication to a child less than 4 years of age can be a question. There aren't many conditions that require medications for children this young, and usually we do a good job of treating them. They respond pretty well to parenting strategies or changes in their setting. Then you'll see children that have kind of a layering effect of medications where you see medications added on that kind of do the same thing. So medications that have the same target, such as sleep or aggression, may be layered, or if they belong to the same class of medications, like 2 or more antidepressants, anticonvulsants, or antipsychotics. This doesn't apply to long and short-acting stimulants for ADHD of the same general class. Other medication patterns that may be concerning, if you see this, if you share children with mental health providers, if you feel like they're getting changes every time they see the provider and there's no real good reason, that's a question. Or if you don't know what the diagnosis is easily, that can be a question that we may want to think about. Then finally, looking at doses that are too high or too low, medications may be unnecessary and it's time to take a closer look at them. So you can track your doses on Hippocrates and get a good sense of what the dose strategy is for pediatrics. So in Hannah's question, the only medication indicated in her list was Adderall XR for ADHD. She was on polypharmacy, she had a really young age, and there's a fair amount of therapeutic duplication, including a couple of medications for sleep. So in this situation, you'll talk to the child, the family, youth, get a good idea of what you want to do, and then you might make a decision to lower or stop a medication, and you'll have a general sense of what should be stopped first. If you do this, you want to have a good plan. You want to talk to the family about the role of gradually stopping these medications, what to watch for, cardinal symptoms, things like that, for mood and behavior problems. And you want to do what you can to keep the child active with wellness activities, exercise, things like that that can keep them healthy and have a good sense of what to do if there are problems. In general, when you stop medications, I don't recommend stopping them suddenly, even in the case of psychostimulants, where it can be, from a pharmacokinetic and pharmacodynamic point of view, it's easy to do so. But you want to generally lower them by 50% or so each time you visit. So this can be an ongoing process. And if you're lowering the medications, you want to have make sure that you're having evidence-based therapies in place. These can take place along with medications. They allow the taper to go ahead without problems, and usually include some sort of parenting management or anger management for disruptive behavior. If it's a case of autism or developmental disabilities, you're going to be having programs like speech, occupational, physical therapy, or applied behavioral analysis to be sure that you're getting other things in place too to help. You don't want to be prescribing medications by yourself most of the times. Some guidance here, there are certain things you can do. For stimulants, you can really stop medications pretty quickly, but still, we recommend a gradual taper over a couple of months to minimize side effects. Drug holidays are pretty common, and this is a useful way to understand if medications are still needed. A lot of times these take place over the summer or holidays. If a child's been on a medication for several years, you can understand if they still need this. From some research that we did recently, we looked at ADHD and stimulants. And stimulants have great evidence for their use. And there's a lot of evidence that suggests that stimulants continue to be effective throughout the lifespan, reducing things like negative outcomes, arrest, criminal behavior, substance abuse. But even in those studies, there's a subgroup of patients and children who don't worsen when the medication is stopped, up to a third across most drug studies. And so the challenge is really finding that group that doesn't necessarily need the medications. And probably it's along the lines of looking at children with uncomplicated ADHD with good networks, support networks, things in place that may be most likely candidates. If you're going to deprescribe an alpha agonist, it's important to do so in a very gradual manner, because if you stop an alpha agonist, suddenly it can rebound and cause hypertension. With serotonin reuptake inhibitors, a general logarithmic reduced by 50% every month is best for avoiding discontinuation syndrome. You don't always see this with fluoxetine, however, because of the long half-life. After you deprescribe, and if you're lowering or stopping medication, it's important to have a safety plan in place where you can catch problems if they worsen. And also you can evaluate if this is something where medication is needed, or if it's something that can just be attributed to psychosocial events or therapy. So pay attention to those social determinants of health that can make a difference. And we want to monitor for any educational or social effects as well afterwards. If a child is having trouble in school or with friends, that might mean that we want to change and look at medications again. So there are possible benefits of deprescribing. In general, having children on less medications, the only medications that are needed and are safe, is going to reduce your likelihood of drug reactions, may improve the overall compliance, and certainly can help factors of cost. I do think that you're going to work with patients and families to help build their coping strategies in case they start to have issues or problems. The risk, I think, of deprescribing is that the medications can be effective, and there is a chance that a child may start to have more problems. I hope that if you do this, you'll have a safety plan in place and you'll catch it and you will understand if a medication is really needed. It's important to have family assent with this to know that they're going what they're doing, that they're okay with this. And problem would be that if you're not able to have a quick role or a consultation with a child psychiatrist or mental health provider, it may be harder to really carry this on. So you may ask, what is the role of the pediatrician in deprescribing? So I think that we look at pediatricians to treat ADHD, depression, and anxiety. There's never going to be enough mental health providers to treat what's needed. And so I think it's very helpful and important that they're treated in primary care. And so you may be seeing patients where you find children have been on medications for a while and they seem to be doing well. Pediatricians provide a lot of important gap care for children who have psychiatric conditions, such as those that have been discharged from hospitals, or they're between providers. In the case of foster care, children often move from provider to agency, so it's hard to know. And as a medical home provider, I think it's very helpful for you to be involved to look at common side effects we may see with medications. That includes weight gain, movement abnormalities, sedation. And I think that you're in a position to coordinate the care. Some specific information about antipsychotic medications that would be helpful. Now, pediatricians may not start these medications, but you will likely inherit and see patients who are prescribed these. And so your role with antipsychotics may be more as a medical home monitor. Well, just remember that this is important. Shows that even within 12 weeks, when you use an antipsychotic medication, it can change the percentage of total body fat, the change in subcutaneous fat, and insulin sensitivity. And the slide compares 3 different antipsychotics. And if you look carefully, you see that olanzapine is the medication with the greatest change and the greatest risk factor for change for body fat, subcutaneous fat, and insulin sensitivity. So knowing a little bit about the certain types of medications involved may be helpful. Olanzapine is one that works well, but it has significant side effects. Various studies have shown that type 2 diabetes are much more commonly associated with atypical antipsychotics or second-generation antipsychotics. This is a grouping of studies that shows that compared to healthy controls and psychiatric controls, children treated with antipsychotics are much more likely to develop type 2 diabetes. So at each visit, checking for subcutaneous fat, waist circumference, and every 6 months checking a lipid panel and a fasting blood glucose is important to do. And if you have children who are on a lot of medications, the risk for type 2 diabetes can increase. The greatest risk in this study was seen with tricyclic antidepressants, which we don't see too much, but occasionally you'll see doxepin or amitriptyline being used for children to help with sleep or sometimes incontinence. But other antidepressants like fluoxetine or sertraline, these SSRIs, are also associated with elevated absolute risk. So combination of medications can increase the risk as well. So pediatricians have a role with monitoring safety for antipsychotics, which includes keeping an eye on these side effects, making sure that we're checking labs every 6 months. And if you don't prescribe them or feel comfortable stopping them, having a discussion with the youth and the family to prepare them to speak to the psychiatric provider, the child psychiatrist, or the nurse practitioner. And certainly contacting the prescriber to raise your concerns is appropriate. Some scenarios where we think deprescribing can help include the diagnosis of a child with ADHD who's been pretty stable for several years, and you haven't had to increase the medications. Grades are good, family's doing pretty well. that could be a case where you may reconsider if the child still needs some medication. This could be an example of a drug holiday that can help. If you have a child who's being treated for depression or anxiety as a primary condition, and they've been treated with antidepressants, which are also used for anxiety, for a year, and they're doing pretty well, and you don't have a lot of psychosocial stress, I think you could start to lower and stop the antidepressants that are treating the anxiety or depression and see how they do. Make sure they have supports in place. We see children with destructive behavior. Certainly we see them in foster care with destructive behavior that are treated with antipsychotics. This can be related to trauma or other things. And the goal is, if we get them to a safe place, get some good therapies involved, they may no longer need the antipsychotic medications. And certainly if you have these children that are getting side effects or weight gain or things like that, metabolic dysfunction, you might be more likely to stop or lower the medications, or recommend that they speak to the provider about that. So one big piece to this involves having access to mental health for consultation. So I want to get an idea from folks, how many of you feel like you can get access to a child psychiatrist quickly? So many of you don't, and that is a concern. And to try to get at this, several states have introduced child psychiatry consultation lines. Massachusetts, for example, Washington, and right now about 30 states have this. We don't have this in Kentucky, but I would like to see this take place at some point. I know that here within Norton's, we have access to Epic Chat, and hopefully you have access to Child Psychiatry Division at Bingham, where we can help consults. Each of us have a number of colleagues that we routinely reach out to and share and curbside information like this. In addition, our state university partnership developed a pilot program with 2 sites within Norton Healthcare and University level Pediatrics. We are working with pediatricians at Stone Street and Novak to pilot this deprescribing. We have a website with toolkits and resources that we have available. We are encouraging the primary care providers to use a deprescribing dot phrase in Epic when they see children with psychotropic medications, so that we can track this. I'll share a little bit about the toolkits and resources that I hope you can access and use. And for pediatricians, I think we're wanting to target certain medications more than others: stimulants, alpha agonists, antidepressants. And the idea is that we pilot this and would then offer it to more mental health providers as well across the board. And so for this pilot, we have co-located psychiatrist, Dr. Goldstein, and the rest of Bingham faculty that can provide support for deprescribing. This gives you an example of some of the information. This is a short version of the deprescribing information that we would ask that the caregivers have access to, that talks about what it is, why we might do deprescribing, defines what medications are and how they can do, how they might go about it if they're interested. And it mainly involves talking to the providers, understanding each and every medication a child takes, and being able to consult with the providers. We have a similar website and toolkit for providers that talks about deprescribing. Again, what it does and why it might be appropriate. We have on the website some of the considerations and reasons why you might want to think about it. Like the child's getting better, is on a lot of medication, young age, youth request. And in each of these, we talk about how it might work. So we have toolkits for families, prescribers, DCBS workers and youth. We've also developed individual toolkits for medications too: alpha agonists, stimulants, antidepressants, and the antipsychotics. Each of these are available on the website for download, and I hope that you can use them. I want to be sure to share them with you. In addition, we have the Deprescribing Pilot that we spoke about, and we're tracking a QI project right now. Dan Arnold is a pediatrician at Stone Street who is helping champion this. And so our goal is that we'll have 75% of clinic visits of children on medications will have a deprescribing assessment that we can track on Epic. And so we're asking providers to use Epic a lot to do this. And you can look at .deprescribe to get to this Epic smart phrase that we have developed to make it easier for you. The idea is that of these children who have a deprescribing conversation, you'll have 15% of these children that have a decrease, some evidence that some action was taken that includes a change in medication, stopping it, or reaching out to a prescriber. We're tracking balancing to be sure that this is not an adverse action. So we're looking at presentations to the emergency room, and we're also hoping to have a high level of provider satisfaction with this process. This slide details what the deprescribing dot phrase is, and that you met with the youth or family to look at the medications. You can pull the medications to the node so that it auto populates, and you can describe if the medications are prescribed by the providers or not. And then you talk about the utility of the medications discussed today and decide if you're going to have some action. These are all prompts within the dot phrase. And from the Bingham Clinic support, we are available on site. We have the Norton Healthcare Online here is being developed, and we have Epic Chat for access to this. So in summary, deprescribing is a discussion between the provider, the youth, family, for looking at the risk, benefits, the balance of the use of medications. And deprescribing itself involves a systematic evaluation of each and every medication a child's taking to understand if it's right or not. So I encourage you to look at the website and develop this, or use a QR code to help. Some references for you to share, and that is the end of the slideshow. So I'll stop sharing. Have a chance to look at chats and questions.
All right, Dr. Lohr, some questions for you. So parents of children treated with stimulants for ADHD commonly will stop the medications when they come to the clinic. Is it okay to stop psychostimulants all at once in children?
I think it's possible and it can be safe, but the best outcome would be to stop it gradually, if you could. If you're going to do like a summer drug holiday, you may not have a lot of time, so you may want to do this quickly over the course of several days versus weeks. But if a child is on a lot of medications and you stop stimulants suddenly, it can lead to some adverse events with the others. So some caution is advised there.
Okay. And then how often are physicians or APRNs in that program you talked about deprescribing, how often do they complete these assessments?
Well, the goal would be each and every time, because it's really a mindset. It's a philosophy of treatment that every time you have a child in front of you, you look at the medications that they're receiving, the medication list, and you go through in your mind a check balance of do they need each and every one. I think the deprescribing materials here force it to be a little bit more formal, where you go through this. But the best case would be every time, but if we could do it quarterly, that would be wonderful.
Okay, and then the toolkits you were talking about, is that the QR code you showed?
Yeah, that takes you to the website, and
Okay.
the website has the each of the materials that I showed today, even better versions of them.
And then I think Karen put the website in the chat. So those watching, if you want to click on that link, you can get to the toolkits for deprescribing. Another question, how much success do you have in deprescribing antipsychotic medications for irritability in children with autism?
Well, that's tougher because first of all, the irritability with autism can be multifactorial, and hopefully before they're even placed on antipsychotics, they're looking at all the medical and psychosocial rehabilitative therapies that can be placed. And so if a child is getting all these therapies like ABA, speech, OT, and working with people, and they're starting to do better, you can start to lower the antipsychotics. But autism can be difficult to treat, and so it's difficult to say for sure.
Okay. And if I have a patient in clinic that's on antipsychotic medications that I didn't start, and I'm not really comfortable stopping another physician's medications, but the child's gaining weight, what would you recommend doing?
So if you're not comfortable stopping the medication, I think you would talk to the family and the youth about the concerns about the weight gain or the metabolic side effects. You could be sure that you're monitoring lipid panel, blood glucose, encourage wellness activities like diet and exercise, maybe get them hooked up with a nutritionist or a dietitian, and encourage them to speak to the provider, and you could speak to the provider yourself. I would hope that we have access to their psychiatric providers where we could reach out and curbside and say, hey, I want you to be aware, this case of the child's gaining weight. Can you think about doing anything else?
In your division, people utilize Epic Chat for some of these things for you all?
So I hear.
Oh, okay. Another question, what if I have a patient with generalized anxiety disorder? When is it appropriate to deprescribe medications, or should these patients remain on their meds, for their lifetime?
Yeah, so generalized anxiety disorder is, I do think this is not a condition that generally lasts forever in children, because it is linked so much to social factors, social determinants of health. So if those get better, that can be a change. And anxiety can be, within a year or two, it has a natural course and may resolve. A lot of it depends on past history, how severe it is, and how many cases of anxiety or depression a child's had.
Okay. All right, Dr. Laura, that's all the questions. Appreciate
Thank you,
your
Mark.